It's a pleasure to have Dr. Kolb here talking to us about the challenges and strategies to screening for Barrett's esophagus and esophageal cancers. It's an excellent segue from our endo conference. So Jen, we're happy to have you here. Thanks for joining us today.
Thank you. Hi, everybody. Great to be there virtually. Can everybody hear me and see the slides okay?
Yes.
All right. Okay, well, so today I'll be talking about challenges and strategies for screening for Barrett's and esophageal cancer, which I'll use interchangeably. But I wanted to start off for Colon Cancer Awareness Day talking about a success story in GI cancer screening. And so, as we all know, since the 80s, 90s, we've had significant impact in the incidence and mortality in colon cancer. And that's largely due to uptake in colonoscopy. And if we think about why this program has been so successful, colon cancer is common. We have a universal screening program. There's also a higher risk, targeted screening. By and large, it's well accepted that there is a mortality benefit, that this is USPSTF endorsed. There are multiple testing options. We have a good amount of patient acceptance for various different testing modalities. And we also have shown some cost effectiveness data. Now, what I'm tasked with talking about today is going to be, why is esophageal cancer not the same success story? Why is this not what people are talking about on SNL skits? And I think the first thing to make a point is that esophageal cancer is just less common. It is not really being proposed as a universal screening. We have a focus on high-risk targeted screening for a specific subgroup, which we'll talk about. It may or may not ever be possible to show a mortality benefit. Up until now, we've largely relied on upper endoscopy as the only type of screening test for esophageal cancer, though there are some new tests in the pipeline. We don't really know how patients feel about this. We don't really know if patients are aware about it, and the cost is really a big question. And so that's sort of the outline for my talk today. And so starting out by looking at how common esophageal cancer is, well, it's not even up there as one of the top 10 most common cancers, new cases in the US, compared to something like colon cancer. It is number 7 among men for estimated deaths, but this is SEER data that actually includes squamous cell as well. And for the remainder of the talk, really, we're just talking about adenocarcinoma because we're talking about Barrett's. So to put this into context, we have about 20,000 cases suspected a year in the United States and about 16,000 deaths from esophageal cancer in the US. Now, even though it may not be the most common, it is increasing in incidence and it is quite deadly. This is data from SEER over the last few decades, and you could see that there's a steady increase from the 70s, 80s, 90s. It has potentially started to sort of plateau or level off in the last 5 years, but by and large, what you're seeing is this large increase. And if you just look at the yellow line, that represents all ages, but the gray line, which is the elderly group, so 70 and plus, is really what's driving this increase in incidence. So we have a cancer that's becoming more common, and that's more common among the older population. And we know that this is a cancer with a very identifiable precursor lesion. Barrett's esophagus turns into esophageal adenocarcinoma over time. And so if this is the precursor lesion, then we should have a much easier time setting up some sort of a screening or early intervention, early detection protocol. Now, the reliability of that is really based on the diagnosis of Barrett's requiring 2 things. And this diagnosis, this does vary in different countries, but for the purposes of today and what we think of as Barrett's, you need the 2 things, as you guys, as you know, and as you were just discussing, which is having the columnar lined esophagus on the endoscopic views, at least a centimeter into the esophagus, along with histologic findings of intestinal metaplasia. Now, if you have this histologic precursor, then again, early detection and intervention should be possible. But this has been questioned. And so a few years ago, the Mayo Group came out with a sort of very provocative statement saying, well, is it true that all esophageal adenocarcinomas come from intestinal metaplasia. And they sort of demonstrated that there may be a subset of these cases that don't have intestinal metaplasia. So this was some work that we did at Colorado to look at our own subset. We took 475 of our esophageal adenocarcinoma cases, our specimens, and we looked at them to see, do they for sure have this precursor? We separated them into the presence of intestinal metaplasia. This could be based on prior biopsies that showed Barrett's. This could be based on any prior record saying at some point on any endoscopy, this individual had a diagnosis of Barrett's esophagus. We then also looked at the surgical specimens, at all the biopsies, had them re-reviewed by an expert pathologist, and still came up with about a quarter of these esophageal cancers did not have any identifiable intestinal metaplasia on histology or clinically a history of Barrett's. And what were the differences between these two different types of cancers? Well, the ones that didn't have this intestinal metaplasia, that's Barrett's, really were worse off. They had advanced stage, so more likely to be stage 3 and stage 4, and they had poorly differentiated, so worse histologic features. And so not surprising, because they had sort of all the bad things lined up for them, they did worse. So those individuals had poor survival compared to the cancers that clearly demonstrated intestinal metaplasia. And so I think there's a few different conclusions from this, but the important one is that, does this really demonstrate that there's a non-intestinal metaplasia pathway to cancer? Probably not, but it is interesting to note that there is something that happens in a subset of these tumors where the intestinal metaplasia is no longer found. And there's a few different theories for this. Is it possible that most likely this is just a very aggressive, these are sort of the worst of the cancers, they're very aggressive, there's tumor overgrowth, and it's strictly a phenomenon that, of course, the cancer overgrows the Barrett's, most likely. Is it possible that there's a genomic catastrophe? We know that there may be some of these cancers that rapidly progress, that may be from short segment Barrett's, that we can't understand why the time frame for their development is rapid and why they are associated with such poor outcomes. But is there really an alternate cell of origin? Probably not. And I think more likely what we could think of this as is that potentially there's an alternate phenotype, that there's an alternate not pathway, but a different phenotype that may be useful for us to understand prognosis and to then frame how we intervene early on these potential cancers. This was really nicely demonstrated in a modeling study by Kit Curtis, John and Adomi's group that pretty much set the record straight on this. So they looked at sort of all of the cancers that you would expect based on the clinical development of the normal esophagus Barrett's through the pathway to cancer. And they calibrated these models to SEER data. And they basically said, well, how many cancers should we expect to find in the US based on how many cases of Barrett's are there? And luckily they were able to show that dotted lines represent what their models predicted, and the dotted lines show what the actual findings are using population-based data. And really they showed that every single case that we are seeing can be attributed by Barrett's. And so this sort of puts to rest this concept and helps us to then move forward to say, really, we can be certain that we will catch or that we are potentially addressing all of these cancers if we look at all of the Barrett's cases, even if it doesn't always seem like all of these cancers may have had a history of Barrett's. So if we proceed with this framework of progressing from normal squamous epithelium to Barrett's esophagus, to Barrett's with low-grade dysplasia, to high-grade dysplasia, and of course to cancer, this provides a really nice pathway for intervention, with the goal being to identify Barrett's before cancer, and of course to intervene with things like surveillance and/or endoscopic eradication therapy for Barrett's-related neoplasia. Now, not only can we intervene early, but we know that esophageal adenocarcinoma is stage-dependent survival. This is also SEER data that shows the distribution of cases, localized, regional, and distant. And what you see is that, first of all, distant and regional are at least as common as localized. Not what we'd like to see with these types of cancers. And really not much has changed in terms of the distribution over time. The majority of patients continue to present with advanced stage disease. And of course, survival is related to that. And so localized disease, very good survival, largely because of improvements in endoscopic eradication therapy for Barrett's related neoplasia, whereas regional, distant, there's not much you can do for these cases. And then the fact that we all keep saying and finding and trying and sort of being frustrated with is the fact that if you look at all of these cancers, large meta-analyses, multiple studies have showed these, every patient who shows up with esophageal adenocarcinoma, so many of them don't have Barrett's, and Barrett's is often found at the time, and only about 12% of these cases are really have a history of known Barrett's, or they were in some type of a surveillance program, or they knew about this diagnosis. And so this is largely the rationale for screening, is that right now our referral practices are completely failing to identify these high-risk patients. So all of that sort of builds the rationale for esophageal cancer screening. We have a very well identifiable precursor lesion. We have stage-dependent survival. We believe that screening and surveillance will allow for detection of cancer at an early stage, whether it's by doing ongoing surveillance in a non-dysplastic patient and catching them before they develop a lesion. And we know that minimally invasive treatment options for early stage disease are available through endoscopic eradication therapy. Whether or not early detection leads to better outcomes, I will leave it as a question mark. Not gonna focus on that as much today, but I think there is sort of the elephant in the room that we need to mention, is that we don't have strong survival data to show that surveillance for Barrett's is, that it really is effective. I mean, we have strong observational data, but whether or not we'll ever be able to show that continuing to survey non-dysplastic Barrett's saves lives will be difficult. And the reason for this is because there is such a low risk of progression, and few cancers come from Barrett's, even when you're following them over time. And at a population level, there's a low incidence of cancer. So I think these two facts are important to keep in mind, especially for the epidemiologists and, for the modelers when we try to put together guidelines that are really acknowledged nationally by other societies outside of GI. But these are two things just to keep in mind. But I don't think that they really should preclude anything that we do, because as we know, everything else that we're going to talk about still really points to the benefits of moving forward with some sort of a screening and early detection program. So who to screen? Universal screening, do we just say everybody should get an upper endoscopy when they come for their colonoscopy, or a risk-targeted approach? And we don't have any guidance from from internal medicine colleagues. There were some prior suggestions and guidelines about how to screen for patients with GERD. Should we do upper endoscopies? But nothing's been updated in many, many years. And so what we're really left with is just our own set of guidelines. So all internal. Most GI societies worldwide have some set of recommendations, guidelines, whatever you want to call them, that some have strong evidence, some are not using, great or any strong framework for evidence. But essentially, we are screening according to risk factors. And if you look across the board over the years, there's variations, but pretty much everybody says you have to have at least a risk factor or two. The risk factors are the same. We're really focused on elderly and men who are over 50, who are white, who are central obesity, smoking history, family history certainly plays a role. And some variation of these risk factors is really what drives these guidelines. Now, GERD, as you'll notice, is also pretty much the driving risk factor for all of these. And in general, GERD is usually a prerequisite for any type of screening. So if you have GERD plus, that's when you usually start screening. Now, I will mention one exception, which is that the recent AGA guidelines have really removed GERD and said that GERD isn't required if you have the other findings. So why do we screen according to risk factors? We have very strong data showing that Barrett's is related, that Barrett's is higher prevalence based on these risk factors. This was a nice systematic review meta-analysis that looked at different studies from different parts of the world and different risk factors, and what is the prevalence of Barrett's based on these. And you can see that it goes up as you add risk factors. So prevalence of Barrett's is low, just a few percent in individuals with just one risk factor, but once you get into GERD plus, you're already at the 12%. And that's a risk-enriched population. That's a population that we could really consider in screening. They also nicely demonstrated a linear increase in the prevalence of Barrett's by 1.2% for every additional risk factor. And again, family history seems to play in really strong here. But we know it's challenging to sort of only screen based on family history. So how well do these guidelines do? These risk-related guidelines, not great. This was a study out of the Houston VA. They looked at 500 plus patients. Everybody comes in for a colonoscopy. We'll do an upper endoscopy at the same time. And the goal was really to say, well, how well do these guidelines do when you put them up against, real scenarios where we have outcomes data. And so they identified 44 cases of Barrett's and 469 controls. So their prevalence was 8.6%. And so with that, the guidelines didn't do so great. These parameters are not what you would want out of a true screening test for like a upper endoscopy. And you can see the ASGE 2019 guidelines, 43% sensitive for picking up Barrett's in these individuals. But then they did an interesting thing where they changed the guidelines to say, what if we did it with requiring the presence of GERD and more risk factors, and then they were able to bump up the sensitivity and specificity. And so I think this sort of reminds us that although we have variations of these different risk factors put together, we still haven't created really the right fit for our population to really capture all the cases. And part of the reason for that is we have GERD is very common, right? So probably 2 to 3 in 5 people in the US have GERD. And so if we focus on everybody who has GERD, there's too many people, and we know Barrett's is not that common. And so this presents a real challenge to us. And of course, we all know with the increasing obesity epidemic, GERD is going to become more and more common. And so when we have such a common, or when our entry risk factor is this common, we have to question, is this really still, targeted screening? And of course, the definition of GERD varies considerably. Is this GERD with symptoms? Is this somebody who feels their reflux, feels their heartburn? Is this somebody who has taken a PPI and maybe isn't experiencing the chronic reflux that's contributing to damage and development of intestinal metaplasia? Because GERD is very poorly defined overall. And so that really highlights these limitations of Barrett's screening, which I think even was being mentioned as I signed on the talk today, which is that, if we look at all of our patients who have GERD, Barrett's is only going to be present in about 10% of them. So that's 90% of people you're looking for Barrett's and not going to find it. But on the flip side, when you look at all of your cancer cases, you're also not going to find Barrett's or GERD rather, any symptoms in about 40% of these individuals. So again, the pieces of the pie are not lining up to something optimal for us to sort of target these individuals who are at risk. So how do we move beyond just lists of risk factors and GERD? Well, what we've seen is the development of risk prediction tools. Many of these have been around for years and have sort of demonstrated different performance characteristics. I'm just going to focus on a few of the more recent ones that are still being applied to populations. So the Barrett, the Hunt, and the Koonsman. And what these are risk prediction tools that do incorporate a lot of the same exact risk factors, a lot of the same GERD questionnaires, a lot of the same, demographic, but they certainly weigh the different variables differently. And so the Barrett tool, that's been mostly led by Joel Rubenstein and his group. The Hunt tool, this is Nordic, and Koonsman is using a prospective cohort in UK. And they've developed these risk prediction tools to say, based on these factors, what is the risk for Barrett's, or largely most of these are, what is the risk for adenocarcinoma? So how well do they perform? So this was a study that was done with 1,241 patients who came in for their first upper endoscopy, or if they had known Barrett's, for their first endoscopic eradication therapy, again, led by Joel's group. And they looked at the ability of these tools to predict Barrett's and neoplastic Barrett's. And what did they find? Well, the most important thing is that all of these tools outperformed GERD alone. So again, some way of putting together a risk formula did better. Now, the area under the curve is about 0.66 to 0.7. And I think this still leaves a lot of room for improvement, certainly, but it's already showing that these can outperform GERD, and that's important. This was looking at predicting Barrett's. And then they also did the same thing for people with Barrett's to look at predicting neoplasia. And the characteristics are a little bit higher, but again, we're seeing that these risk prediction tools definitely offer more promise for identifying those patients who will have positive findings on endoscopy. Another interesting study by the same group using these same models actually looked at how well these predict cancer, and similar, the same thing was found. So these did better than GERD alone. Again, we still have room for improvement, but starting to see that these offer a lot of potential. So what do we do next with these risk prediction tools? How would we even leverage these? Well, I think there's still some decisions to make in terms of whether or not we want to remove GERD as an entry point to screening. GERD still factors into all of those tools, though the Koonsman, for example, doesn't just talk about GERD, it talks about esophageal symptoms, and how are we weighing all the different factors? And then more importantly, how do you operationalize this? Is this a risk prediction tool that is done by a calculator, by MD Calc, where you're sort of plugging it in on your own? Is this something done on the back end? Are these large health systems? And do we trust risk scores to help us stratify patients? So having said all of that and having sort of a better sense of how we could identify individuals, one thing that we didn't really know and we didn't have a good sense of is how would this be accepted by physicians? Can we then just go to primary care providers and say, well, we think these risk factors are really what it is, and this is what we would ask you to do. See what, these are very easy to plug in, these calculators online, and start sending your patients over for upper endoscopies. But in order to really implement widespread screening, we have to sort of understand the barriers, the practice patterns, the attitudes of all of the referring providers. And so as part of an ECB-funded study, we sought to really look at what GI doctors and what primary care providers think and feel about Barrett's screening, just to get a baseline sense. So this was a large survey study done at multiple academic medical centers. We also included the safety net health systems. And we asked questions like, what are your practices? And what do you know about any guidelines? And what do you think would be the barriers to implementing screening, as a way for us to understand how to eventually operationalize this? So of the survey, we had a pretty good response rate, especially from our GI colleagues. So 120 GIs responded, almost 200 primary care providers responded, which was, I think, probably the more important aspect of this study. Most of them are doctors, though there were some nurse practitioners and PAs, and they were pretty, well balanced in terms of provider characteristics. Most of these individuals had a good amount of years in practice. I think there was about 7 was the median for GIs, 12 for PCPs. And especially for the PCPs, we did make sure that these are PCPs who are seeing GERD patients, and not surprising, most of them are seeing at least 5+ patients in their clinic a week with GERD. So these are the providers who are seeing the patients that we ultimately would probably want to capture. And so what did we find from their attitudes? Well, GIs, not surprisingly, are ordering Barrett screening. At least, they're saying more than half of them, we're doing it at least once a month. It's probably a little bit more difficult to parse out, because when GIs order screening, it may be diagnostic, but in any case, we know that GIs are ordering endoscopies. But 17% of PCPs are saying that they're thinking about screening, ordering anything related to Barrett's, and about a quarter of them are referring patients to GI to discuss screening. And I suspect that quarter referring to GI even includes the people who have refractory reflux, which, really that's not even screening anymore. So these are really low numbers, not surprising. And what did they want? Well, everybody by and large wanted more data. More data on the benefits of screening, more data on the harms of screening. Everybody wants RCT data. And this is important because when we talk about the limitations, we may or may not be able to provide RCT data ever. And certainly we can have data on benefits and harms, but is this even achievable? I think is an important question. And so by and large, I think everybody agreed. Everybody said that, we know that screening can improve detection, but we want to know more. And so we created certain vignettes in order to test the ability of providers to distinguish risk factors. So we said, what would you do with a 40-year-old male with chronic GERD and a family history of esophageal cancer? And the vignettes on the top are cases that should, according to the guidelines, technically would be warranted for a screening. And so that was good that 94% of GI, or 94% of PCPs and 97% of GIs really acknowledge, yes, I would screen this person. But you could see that as you mix it up a little bit, those numbers drop off significantly. And so looking at the purple, the PCPs on the top, only 60% of PCPs would say that a 50-year-old male with chronic GERD should have an EGD. And they're not saying whether they would refer or not. They're basically responding, do you think that this patient is eligible? And, only 60%, 50% down the line, even when you add in additional risk factors. And so this really highlights the fact that our primary care colleagues aren't as in tune with the same risk factors and guidelines that we technically may be following. And I think it is different because we consider many of these patients will get an endoscopy regardless whether we're screening or for diagnostic purposes. Now, in terms of inappropriate screening, the most significant is that 67% of PCPs would screen the 40-year-old male with chronic GERD who's actively drinking. And the only reason we included this question is because it's important to separate out smoking from alcohol. But this is something that I don't think has been well explained in our literature because it's not really well known among the primary care providers. And the most important part of this is then, will you even screen, or what are the barriers to screening? And largely GIs don't have many barriers, which is okay. There were some had a few concerns about insurance coverage, which is valid, but PCPs, more than 50% of them said, I don't know who to screen. I have difficulty identifying patients. I don't know the guidelines. And so this is really important for us as a society to recognize that if we want to partner with our primary care colleagues, if we want buy-in, if we want all of our patients who are being seen and serviced really by primary care, this is where we have to start. And so this provides a really nice application for those interventions in the medical record for something like putting a risk prediction model. Most PCPs in general don't order screening or don't refer GERD patients for screening, and they have barriers that are real. I want to show you one other one, which is, so 44% have competing concerns. That's another thing. And you can imagine esophageal cancer screening is only one in a list of many, many other things. And so this is not a priority, and that's okay, but how can we help make this an easier priority for our primary care colleagues? And so some potential things that we can do is educational interventions, potentially integrate reminder systems into the medical record. We have to be careful to not make it more complex, that it actually becomes an improvement rather than more of a challenge for our colleagues. So what have we talked about so far for esophageal cancer that makes it potentially attainable? While we know that it is less common than something like colon cancer, but it's a lethal disease, precursor lesion, we can develop some sort of a targeted screening based on risk models using risk prediction tools. Mortality benefit may or may not be possible to show, but may or may not be necessary. And so then the next step in developing a screening program is there patient acceptance? Is there buy-in? And there was very little data on this, largely because probably many, this is not a cancer talked about as much. And so part 2 of our prior study was to really look at what do patients think. And a lot of developing a program has to really meld to what they want, what our patients want, and what they're willing to do. Okay, so what we did is we looked at we surveyed 472 patients, and we really tried to do a stratified approach, because we wanted to include all different types of demographics. Because the thing about Barrett screening up until now is that we've been largely focused on sort of this one unique demographic, male. But if we're really going to roll out a screening program, you have to be mindful of how all patients, all individuals are going to feel if they are targeted or not targeted. So by casting a wide net, we captured 472 patients. It turns out this was individuals who were at risk for Barrett. So patients with chronic GERD, with any of those risk factors we mentioned before. And not surprisingly, actually 2/3 of them reported that they had a prior EGD. Most of them said it was for other reasons, for symptoms, and they didn't necessarily remember being recommended for Barrett screening. But again, 2/3 of this cohort had a prior EGD. And despite that, the findings were pretty compelling. Most felt that esophageal cancer is deadly if it's not treated, and early detection leads to curative treatments. So that was surprising to see that there was still some idea that this is a serious disease and it can be detected early. But most, at least 1/3 of patients, a lot of them really didn't understand or appreciate the nuances and the risk factors. Specifically, when asked, does GERD increase your risk, obesity, how does smoking? That was something that was not well appreciated. And only half of individuals understood that screening is needed even if GERD is controlled. And this is really interesting, especially with the ability to self-treat for PPIs, because there are probably a lot of individuals who think as long as they treat their acid reflux, then they're never going to have issues and they never need to worry about it, that it's sort of a preventative medication. So when we looked at risk perception, 32% thought that they would get Barrett's, and 20% thought that they might get cancer. Again, this is a completely random sample of individuals just chosen in the medical record who happen to have GERD or fit the demographics. And about 1/4 of them were moderately or extremely concerned about developing Barrett's. So it's a small number, 22%, but to be moderately or extremely concerned about developing that means that there is some fear here, there is some worry. And the large majority of individuals believe that screening is important to their overall health, and they also felt that getting in an upper endoscopy would reduce their level of concern. So we're starting to see patients are interested. Patients want to, risk prevention. And of course, people who respond to these surveys are probably a little more engaged in their healthcare, and there's some biases there. We asked the patients, what are your barriers to screening? And we stratified these results based on whether or not they've had a prior EGD, which is helpful because they've already sort of overcome one barrier. However, they got to the EGD, they were willing to do an upper endoscopy. And so, but still, if you look at the people who, even the ones who had a prior EGD, about a quarter of them said, I don't think I need screening. And even the people who had never had screening, 40% of them don't think they need screening. Again, these are individuals who, according to our criteria, would be eligible for screening. Fear of discomfort with endoscopy was the second highest barrier. And this is also really important. We oftentimes assume that this is this is a benign test. This is something that most patients who are fit enough to undergo a sedated procedure would be able to tolerate. But if there is fear of discomfort, that's something that we can do to sort of address that, dispel that, and understand where this is coming from. Do we have to be more mindful of educating on that these are sedated procedures, those types of things. And then 17% were unsure where to get an endoscopy. And we looked at these differences as well, the barriers by different subgroups, so by race, ethnicity, and sex. And the reason to do this is, again, when we think about implementing a screening program and we only have been probably overly focused on white males, it's important to still understand how other groups will respond. And so what we found is that more Black participants were extremely or moderately concerned about getting Barrett's and cancer compared to other racial groups. And they also felt that getting screened was very important for their health. And this data does track with similar findings from other cancer literature, like in HCC literature as well. And so this just highlights that these barriers really are different depending on the different subgroups that you're looking at. So it was interesting that soon after we completed this data, there was a really, the conclusion from this, I should say, is that patients at risk for Barrett's, particularly racial and ethnic minorities, are worried about developing cancer, but they rarely undergo screening. And they also have a very poor understanding of screening recommendations. So clearly a lot of work here to do to to really even get our patients on board with any type of screening program. So the interesting study that came out right after this was a cost effectiveness. And I'm not going to talk about cost too much, only because it depends what test you're screening with. Look, for the whole talk so far, we've only been focused on upper endoscopy. But what was interesting about this study that just came out last year in gastro is that they actually looked at the cost effectiveness of endoscopic screening, specifically by these subgroups of race and sex. And so they separated into 4 cohorts. So white men, Black men, white women, and Black women. And what they found is that for white men, screening was optimal twice, actually, at ages 45 and 60. These are in individuals with GERD. And this is what was cost effective. And the reason to have 2 screening is because there is some Barrett's that shows up de novo in around age 50, and that's why they accounted for a second screening. So that was cost effective in white men, twice screening. For Black men, they were actually able to demonstrate, I think for the first time, that screening is cost effective once at age 55. And for women, actually, it was not effective. It was not cost effective. So for white women, no screening. They were close to reaching their thresholds for a one-time screening, but it didn't reach there. And in fact, in Black women, there was some net harm from screening. So again, when we think about what our guidelines say and what patients feel and experience, cost will certainly play into it. But we have to be mindful of this data that maybe pushes us away from screening certain individuals who may actually have real concerns about disease. So we're going to move on to how to screen, which I think is part of the more exciting area right now. Again, colon cancer, we're just sort of using this as a model for today because it's Colon Cancer Awareness Day and because we have done very well. We have a menu of option. We know that as long as you do something, obviously certain things are prioritized, but for Barrett's and for esophageal cancer, we largely focus on upper endoscopy. There are multiple different technologies that we can use. So unsedated transnasal endoscopy, this has been around for a while. Some of you may have used it. This can be done in a clinic. You just go through the nares and you can see and identify Barrett's. Breath testing, and we're going to talk mostly about the cell collection devices. I'm not going to talk too much about the electronic nose since I've never actually seen it in person or seen it used, but this is a potential technology. Remains to be seen how this may be incorporated. But there's a lot of buzz about these new cell collection devices, and there's a few different technologies, different companies are making them, but they're pretty similar, all of them, which is that there's some sort of a device, a swallowable device, usually tethered on a string. If it's one of the devices, there's a gelatin capsule that dissolves and you remove these through the mouth. And as these devices are pulled out, they collect cells on the way out. And these are often combined with biomarkers, which can then be tested and you can identify the presence of Barrett's. So how do we think about all of these different tools? So this is just a table that I put together. So this is kind of just a very broad overview. But basically, endoscopy, we know, has to be done at an ambulatory surgical center or a hospital. You have to be sedated. It takes 2 hours, probably at least from the time you get there to leave. There's moderate risk of physical harms, discomfort, and it's costly. And so comparing that to some of these other technologies, the cell collection devices, these can probably be done anywhere, in any clinic, even in a lab potentially. They do not require sedation, 15, 20 minutes, minimal, we say the risk of physical harms, and cost is probably lower. And so all these other technologies are very different. However, as we know, similar to stool-based testing, you really do need the confirmatory follow-up endoscopy if the test is positive. So where that leaves us is that even if you have a widespread screening test, you of course would still need a confirmatory gold standard upper endoscopy. Now, benefit of detection sensitivity is pretty high across all of these. So at the moment, that's not really the issue. 75 to 95%, you probably will catch most things, but there's a very big difference in finding false positives. Of course, upper endoscopy, less likely. But with cell collection devices, and I'll show you some data in a moment, there's a not insignificant chance of having false positives that require acting on. So it's really exciting. For the first time in this past year, our GI societies have actually incorporated these technologies with specific recommendations that these swallowable, non-endoscopic devices combined with biomarkers can be acceptable alternatives. So this is the first time we've really moved beyond just endoscopy for screening. And this was a best practice advice from AGA and a conditional recommendation through the ACG. So what's the best data for this? I'll just summarize one study. There are some ongoing studies in the US on these, but I think the best data comes from Rebecca Fitzgerald's team out of the UK. They use the cytosponge for all kinds of things. They use it for Barrett's screening, for Barrett's surveillance, even for post-cancer surveillance, they're using it now. And so this was the BEST3 trial. And of course, the healthcare system in the UK is different, but they were able to accomplish a study like this, which may be difficult here, but this was a pragmatic randomized controlled trial. They did this across 100+ clinics in England, 13,000 patients, right? That's a lot. So they were able to randomize them. Half of them got the cytosponge and half got usual care. As you can see in the photo, cytosponge, they come into the office, they get this done, they send it off. If it's a positive result, it then triggers a follow-up endoscopy. So 231 people who swallowed the sponge tested positive. So 13% of the people who swallowed it were positive. And these are pretty well tolerated. Just a few sore throats, 1 EGD for a detached sponge is not much. So what was the primary outcome? It was finding Barrett's. So Barrett's was diagnosed at 2% in the intervention group in the cytosponge and 0.2% in the usual care, no dysplasia group. And there were 4 cases of dysplasia and 5 cancers in the intervention group compared to usual care. And so this was an absolute difference of 18.3 per 1,000 person years. This was significant with a rate ratio of 10.6. And so this was a very large study to show a difference, but still, albeit sort of a small difference, but a really well done study, but there are some limitations. So a few things, which is that the cytosponge uptake was only 39%. So in everybody who was invited to take cytosponge, uptake was only 39%. So when we talk about optimal adherence of a screening test, that's pretty low. Okay. This was a population that was enriched for GERD. So they included people with GERD, and still Barrett's prevalence only 2%. So when we're talking about a risk, an enriched population, to still have such a low prevalence, a lot of testing for potential little value. 41% false positive rate. You have to be able to accommodate all these patients who are going to have a positive screen. And then you need to have a pathway in place for them to get the endoscopy, a way to counsel the patients about the findings, and then a way to explain different findings on the upper endoscopy. Another significant limitation is that more positive screens is probably going to lead to more sampling irregular Z lines. Not going to harp on this too much, but this is just an issue in general in Barrett's surveillance, which is that we pick up, and these cell collection devices will pick up IM of the cardia. It's a controversial topic I'm not going to get into, but there's probably a large possibility for more individuals being enrolled in potentially unnecessary surveillance programs because of a sort of positive screen and then an unsure what to do with the findings. And then the other thing is that even though it's great if these cell collection devices can find Barrett's, we need to go beyond Barrett's. We really want to identify dysplasia and cancer. And we also really would benefit from being able to see which patients are at risk for progression and who would derive benefit from surveillance. So not just finding Barrett's, but once you have the Barrett's, then sort of what do you do with it? So the takeaways are really that professional GI societies recommend screening according to risk factors. It's going to be hard to get away from GERD, and whether or not we need to do it will hopefully be aided by risk prediction models and tools. But given the relatively low incidence of esophageal cancer, low number of cancers that come, the low risk of progression, we may never have studies that compare screening to no screening and demonstrate a reduction in mortality at the population level. And we have to ask ourselves as GIs, our primary care colleagues, our patients, is that good enough to still move forward with some sort of a screening program? And until we really address some of these issues with surveillance, some of the issues with taking a patient with 4 centimeter, non-dysplastic Barrett's and knowing what is their risk for progression, or is it 0.2% per year? Is it 2%? We're getting there with things like biomarkers, but until we really have a way to risk stratify all of our patients who are in Barrett's surveillance programs and to really accommodate them as a healthcare system, it may be too premature to open the door to start screening everybody because we don't really know where to put those patients. So I'll end with sort of maybe an overview of what I think the future will look like for Barrett's screening and kind of how we can get there. There may be a preclinical setting with some risk prediction tools, something using the electronic health record. And this is really how the general population is screened for identifying an at-risk population. Then that at-risk population may come into the primary care setting, they may go to their local lab, and they may have a variety of non-endoscopic screening options, cell collection devices. We can potentially and hopefully incorporate non-physician screeners. These, whatever tests these are, the settings should really incorporate patient preferences. And then after that step, you will be able to hopefully identify a true high-risk population who have been triaged on an initial screening test. And then they will come to GIs for an upper endoscopy. This is the confirmatory test. And if they really are Barrett's, then they can be enrolled in surveillance programs or treatment. But beyond that, we really need to then take those patients with Barrett's and be able to risk stratify them, to use biomarkers, P53 and other different molecular assays, to have some sort of a cost-effective program where we can really focus on those highest risk population and know that ultimately we can prevent cancer because we're really focusing on who matters and who's going to progress most. And this will probably incorporate some type of an AI algorithm as well. So this is where I hope we can get to, and there's a lot of great work being done sort of along all the different areas of it. So I just wanted to end my talk by giving a shout out to all my amazing mentors back at Sinai, who I'm not sure if some of you are on the call, but this is really where it all started. My first time that I ever presented at DDW or had a poster. And so grateful to Dr. Eisenberg and Dr. Way and Dr. Rubin. We wrote an amazing textbook, which was such an awesome experience, and really cultivated my sort of appreciation for GI cancer and GI research. It's been great to stay in touch with everybody in my Sinai family throughout the years. And I am just really, this is very special to be here and to be giving this talk today. And so thank you again for the invitation. And I'm happy to take any questions.
Can they hear?
Yes.
Hi, Dr. Kolb. For that Rubinstein paper that was looking at the risks of screening, like white men compared to different races and sexes, how many patients, like how many Black male and female patients were there relative to white males?
So what did you, can you say that again? You're talking about the model study?
I can't remember which study it was. It was looking at the
Columbia University study.
Like the risk, yes.
It was from Columbia that came out in 2020.
Yeah, that looked at the risk and the risk versus the benefits of screening in white men compared to white women compared to Black men.
Oh, the cost effectiveness analysis.
Yes. I was just wondering how many patients were in each group compared to white men.
This is a model.
Oh no, I think I misunderstood what kind of study it was.
So they'll just put in.
Yeah.
On a model, it's not a.
But it does raise a question that I have. Hi, Jen. Thank you so much for a great talk. Great to see you. How much of this white-black or white other difference is really access to care, social determinants of health? I think for most conditions where you find a racial difference, a quote racial difference, it's not the biology as much as it is the sociology of it. What do we know about social determinants of health and access to care, insurance, those kinds of things?
Yeah, I agree. I mean, we have very good data on outcomes for esophageal cancer and Barrett's, that they're really impacted by social determinants of health. So minority groups have worse outcomes after esophagectomy. The Barrett's endoscopic eradication therapy is worse. They have less access to even getting endoscopic eradication therapy and early therapy. So I think if the outcomes for Barrett's and cancer are worse, then we can assume that the access to sort of diagnostic testing up front is equally flawed. And that's why I think we have to be careful then to just focus on one group for screening, because we're just propagating that same issue, and it may be inappropriate.
Yeah, and like all of those recommendations are, white males, everyone says white males. So it gives the message that everybody else is not important. And I think that is dangerous. I'll just add the TFF3, which is the marker in the cytosponge. It used to be called intestinal trefoil factor, and Bruce Sands is the one who actually cloned that gene when he was a fellow under Dan Podolsky's tutelage. I always, so the reason that even works at all is because Barrett's esophagus, you get the intestinal metaplasia, as you said, and TFF3 is a marker of goblet cells. So if you have goblet cells, you're going to express TFF3. But you said you have your own data to show that in many cases, you don't find intestinal metaplasia for the reasons that you described. So I don't think that test could ever be good because you're going to miss Barrett's that doesn't have the goblet cells or where it's, you know, so it never made sense to me. I never understood why that test did not incorporate P53 staining. You know, it's like so stupid to me. If P53 is the marker of progression or the best we have, why not look at TFF3 and P53? I know you didn't develop the test, you're not in the company, but you know, it's like, I don't get it.
Yeah, that's a great fact that Dr. Sands cloned that. Yeah, I mean, I think for the surveillance, all the molecular assays that are looking at risk of progression, tissue cipher and those types of things, they're definitely incorporating all of that P53. But yeah, from a screening standpoint, I mean, even though cytosponge is really well used all over the UK, I mean, you can't do it in the US even yet. There's not even, like, they've struggled to implement labs to even get this. Like, you can't even get the test commercially, it's not commercially available. So it's still far, I think, from being ready for prime time. So maybe, yeah, and it may not even capture all the right people. Okay, any other questions? You did? All right, thank you so much for being with us, Dr. Kolb. Yeah, I think we're going to wrap up here. Thank you.
Thank you, Jen. Great to see you.
Thanks. Nice to see you. Hi,
Thanks for
Dr.
waking up early.
Bye-bye.